Well, thank you very much, Dr. Peluso, for that very kind introduction, and also for this invitation to speak today here. It really is an honor for me, particularly having worked at Cleveland Clinic for over a decade. I have many friends still there, and really do consider this an honor to present here today and to learn with you all. I also want to thank Kelly and Tracy for all they have done in the facilitation of this process. So thank you, and it's really nice to be here with many, many friends I have in Cleveland. So can you hear me?
Yes.
Okay. Sorry, my computer is acting up. These are my disclosures. None of these relationships are relevant to this presentation. So what I wanted to do was, you can still hear me?
Yes, we can.
Okay, sorry. These are the objectives of today's talk. What I wanted to do was, it's impossible to review the entire subject of neonatal interventional cardiology, but I really wanted to go over the recent developments in our field, focusing on PDA stenting for ductal dependent pulmonary blood flow, PDA closure, and neonatal thromboses. And I'm not going to spend a whole lot of time talking about PDA closure and the literature, because everybody else on this call, other than myself, are really the experts in terms of defining this field and the data that is out there. And I continue to learn from my neonatal colleagues, but I will touch a little bit upon transcatheter closure and how that may impact this particular patient population. So first we'll go to PDA stenting. So I can't give this talk without going over this first slide. So this was the first blue baby operation, the BTT shunt, that was performed in 1944. And you can see here Dr. Vivian Thomas, Dr. Blaylock, Dr. Tausig, and this is actually Dr. Denton Cooley, who recently passed away here in Houston, who was really a pioneer in our field. So it all started out, of course, in the surgical field, but nevertheless, we do owe a lot to these true legends who have who really helped shape our field over the years. So stenting of the arterial duct is not a new technique, but it did have to be refined over many years to get where we are right now. So in 1992, Gibbs et al. Stented the first arterial duct as a palliation for pulmonary atresia, and back then they were using really bulky stents. So much so that the first one of the first stents that they implanted, they could not see it on the X-ray, and they actually just thought it was similar to adult coronary arteries, that you won't be able to see this stent on the X-ray. But they later found out that actually the stent was never deployed in the patient. It was pushed backwards off the balloon and was unwittingly discarded inside a hemostatic valve. Gibbs et al. Went on to publish this report in which they concluded that ductal stenting cannot be recommended. And this was in 1999. Again, equipment was bulky, experience was early. So many authors and many investigators, I should say, over the years have really contributed to refining this technology over the years, where it is now considered not just an acceptable, but often preferred method of establishing ductal, securing ductal dependent pulmonary blood flow in a stable fashion. So these are two studies that were recently published in the United States and UK. This is the study from the United States. And here you can see here that the freedom from death or unplanned reintervention to treat cyanosis was no different in the PDA stent and the BTT shunt group. Reinterventions were more common when you stented a PDA, but still that most of these reinterventions were considered planned reinterventions and were not urgent. the UK, they found out in the same issue, actually, a multi-center article was published, and they found out that the survival was better in patients who received a ductal stent. However, the ductal stent group was at higher risk for reintervention, as you can see here. So one of the impediments to adopting this technology has been the fact that these ducts come in all shapes or sizes, and some of these ducts in the past were not amenable to stenting. So this often comes up in the neonatal unit. If a duct is too tortuous, can we really stent it? So we and others have done some work recently to address this issue, and also to try to overcome some of these very tortuous ducts and see if we can stent them. So that we came up with this classification scheme that involves a tortuosity index, the origin of the PDA, and a curvature index. And you can see here these PDAs can come in different shapes and sizes. And you can see here this is a straight PDA, so this is a relatively easy one to stent. And these are a little bit more tortuous. The one here in the middle, you can see type 2 and type 3 has multiple turns before it enters the pulmonary artery. And you can see these are just those same examples with stents in place that showing that the straight duct can be stented, and so can the ones that have multiple curves if one is using a variety of different techniques. We also did come up with this curvature index, which basically defines how many curves these PDAs have, as opposed to being straight. Very important in facilitating these procedures in neonates is our access, and you can see here the ductal origin. The ductus can originate from many places in neonates, from the descending aorta, underside of the aortic arch, from the innominate artery, subclavian artery. So all of this really will dictate where we access the PDA to stent these ducts. And you can see here that most patients with PDAs that were stented in this series, 61% originated from the underside of the aortic arch. And these are often difficult to access from the femoral artery. And you can see here the carotid artery was used in more than half of the patients in order to stent the PDA. And I'll go over that in just a second. It comes as no surprise that the more tortuous the PDA is, the more curves there were, or the higher degree of curvature index there was. I think this is a very important slide for cardiologists and neonatologists. And you can see here that these PDAs, as I mentioned, they can originate from a variety of different areas. But what has changed from, say, the early experience that I showed you, that slide from 1992, is that we are now able to perform percutaneous carotid artery or axillary artery access, and that would be this group here, the orange group, and that allows us to stent a majority of these PDAs, which were harder to both access from a vascular injury standpoint in neonates from the leg, but also just because of the trajectory. Sometimes it can be very challenging when you're trying to stent a duct from the femoral artery if the duct is originating, for example, from the underside of the aortic arch or subclavian artery, as you can see here. These slides I'm just going to quickly go over. This just goes over tortuosity and reintervention. Yes, we can stent the majority of these PDAs in this day and age, but it does come at a cost. You can see here that the more tortuous your duct, the higher chance you have of the higher chance there is of unplanned and any reintervention. And also pulmonary artery jailing. What that means is if the stent crosses the orifice of a branch pulmonary artery. And you can see here that if you have pulmonary artery jailing, there is an increased need for both unplanned and any reintervention in these patients. But I think what's important to note, this table goes over those patients who've had pulmonary artery jailing versus no jailing. And you can see here that there's really no change in the pulmonary artery symmetry index and the CATA index. And these are measurements or indices we use to establish the health or the growth of the pulmonary arteries. So PAs can be jailed if one is careful, and you can, and it does result in adequate pulmonary artery growth. There are a number of access routes that we perform when performing that we entertain using when we are performing these procedures in neonates. And this is an example you can see here of PDA coming from the posterior aspect of the aortic arch, and we've gone transvenous. So we've entered the femoral vein. I just wanted to show these slides just to show that we try to avoid entering the femoral artery whenever we can in these neonates. This is a patient in whom we did enter the femoral artery, but of note, this patient is good size. This patient was 3.5 or 4 kilos. So this was a term neonate. Here's an example, just the stented duct afterwards. Percutaneous carotid artery approach is something that has recently been employed by ourselves and others. What this involves in our cases many times is flipping the patient. So instead of the head being towards the head of the table, the feet are. The anesthesiologist intubates the patient, as you can see here, in the normal position. And here you can see the neonate with the head actually in the opposite direction and the feet here towards where, in the place of where the head would normally be. The advantage of this is one can access the carotid artery, the interventional cardiologist, this way, and you can lay your equipment on the table. That way the equipment is not hanging in the air, and you don't lose wires and catheters during the procedure. This simple technique resulted in a vast majority of PDAs that would probably not be able to be stented in a previous era to be stented. So just a simple technique of flipping the patient around and allowing us to get access to the carotid artery instead of the femoral artery in these patients has really enabled us to stent many of these ducts. And this is just a series of images showing how we enter a PDA. You can see here, this is a tortuous PDA from the underside of the arch. We've gone from a percutaneous common carotid artery approach. This is our wire and catheter going across the PDA, and you can see there we've stented the PDA. The other thing that we use in neonates is an example of a neonate who again had a PDA from the underside of the arch, and we're approaching this from a percutaneous axillary artery approach. And that also enables us in similar fashion to access these PDAs that would be very challenging to stent via other routes. It's important to remember that the axillary artery is not an end artery. So what that means is if punctured in the right position, if you were to develop, or the patient were to develop a clot, the arm distal to that area continues to be perfused by the subscapular anastomosis. So it is an attractive access route for neonates with a complex congenital heart disease, particularly for PDA stenting. And here's just an example of a patient who had a tortuous duct that we went from the left axillary artery and were able to stent. So what does the data show? I think it's important also to show data, not just that we can do it, but what about the data? So this is just a paper that was published by Dr. Bowser-Heaton, and you can see here that the carotid and axillary artery was used in almost half of the patients. And you can see here that patients, although this wasn't significant, those patients who were flipped had tended to have shorter procedure times than those who were not flipped on the table. So again, that simple innovation of flipping the patient has greatly, as you can see here from the data, also really helped cut the procedure times, but also made these procedures safer. They do come at a cost, though. Carotid artery and axillary artery access, one can have, you can see here, higher rate of complications. And the one that's most feared is, of course, any neurological complication, which fortunately is rare. But sometimes these patients can develop pseudoaneurysm formation that will need to be addressed either with ultrasound compression or with thrombin injection. So just to give you a case example, this is an 8-year-old neonate weighing 3.5 kilos, so it's good size. This neonate had tricuspid atresia and pulmonary atresia, maintained on prostaglandin, had a vertical tortuous duct from the underside of the aortic arch. Here's that duct, and you can see where it inserts onto the pulmonary artery here on the left pulmonary artery, and very tortuous. So by virtue of this anatomy, we would definitely need to jail the pulmonary arteries with our stent in order to stent the duct. And here you can see here on the 3D image that nicely shows this very tortuous duct that and inserting into the pulmonary arteries right there. So our plan was to stent this PDA via common carotid artery approach. You can see here we've gone from the common carotid artery via percutaneous approach. Here's us navigating the ductus with a wire and a microcatheter. And here's our stent across the ductus, and it's into the RPA. It has to be because there is ductal tissue here that if we left the stent short, it would isolate this pulmonary artery. You can see also there, sorry, I'm going to go back here. You can see here the left pulmonary artery is severely stenotic as well. So we went ahead and placed a stent here. There's good flow through the side cell, and this is what I was talking about, that you can still jail a pulmonary artery, but if, most of the time there's flow to the both the pulmonary arteries if you do that. The patient was doing well at 2 months of age, had slight desaturation, developed proximal LPA stenosis, as you can see here on the CT scan. And this is the follow-up cath via the left axillary artery. And we've gone through the side cells of the stent with the balloon here. So this is how we inflate a balloon through the side cells. These are cells that can easily be opened with by balloons. And you can see here we are reconfiguring this stent. And this is the final angiogram that shows really nice pulmonary artery blood flow via the stented ductus to both the right pulmonary artery and the left pulmonary artery. This patient did very well. At 7 months of age, underwent a bidirectional Glenn operation with central PA-plasty using autologous pericardium and is doing very well in follow-up. So this patient had complex anatomy, and we chose the correct access. And it's important to note that PA-plasty was inevitable in this case, and that was performed just once at the time of the Glenn rather than the surgeon having to perform a BTT shunt and central PA-plasty first. So I'm going to go over PDA closure in this next session of the talk. It comes as no surprise that this is a recent survey, and some of these slides are courtesy of Dr. Sathanandam, who's a colleague of mine, who's done really the most work in PDA closure in the country and probably throughout the world. And this is a survey that we had conducted at one of his PDA symposiums. And you can see here that the neonatologist was sort of split at that time. This was from a couple of years ago, in terms of whether closing a hemodynamically significant PDA makes a difference in morbidity and mortality for children less than 28 weeks gestation. The cardiologist, more of them felt that it did make a difference. I don't know if this is based on data or based on ignorance, but nevertheless, this was what the survey did show. So what are the consequences of a PDA in extremely low birth weight infants? We know it results in prolonged ventilation, intraventricular hemorrhage. It can result in neck, chronic lung disease, pulmonary hemorrhage, and of course, what we fear the most is mortality. What we know is that closure of the ductus arteriosus is delayed beyond the usual age of closure in term infants, in the case of preterm infants. We know that persistence of the ductus arteriosus in preterm infants is associated with a number of adverse outcomes. We know that medical and surgical treatments, they're effective for achieving ductal closure. So none of these points are actually in question. The real question is whether medical or surgical closure of the PDA, and I'm going to add there catheter-based closure of the PDA, reduces the risk of any bad outcome. That's really the question. And again, everybody else on this call, all of you are experts in this field and know much more about this issue than I do. Regarding both experience and, more importantly, data from your own institution and other institutions. So some of the shortcomings of pharmacotherapy: it's only effective in 50% of extremely low birth weight infants, can take multiple doses. Of course, you know, renal function can be impaired, cerebral white matter damage, neck, gastrointestinal perforation, platelet dysfunction, etc. What are the complications of surgical ligation? We know that there's a not insignificant incidence of vocal cord dysfunction. You can get impaired neurological outcome, risk of worsening BPD, ROP, chylothoraces, pneumothorax, cardiorespiratory failure, and acute and severe hemodynamic side effects we've all seen as well. So in preterm infants, this is just a slide showing the acute pulmonary effects in 35 randomized trials. And the data, you can find data both on both sides of the coin, as you all know. But in these 22 trials, there was no difference in terms of the days of mechanical ventilation or OT use. 3 trials showed no difference in blood gas measurements, and several trials reported higher FiO2 requirements, more surfactant use, and longer use of mechanical ventilation. In randomized controlled trials, ligation is associated with prolongation of mechanical ventilation, inducin is associated with increased oxygen requirements, and ibuprofen is associated with a greater need for FiO2 more than 30% at 36 weeks. This is just a meta-analysis. This is a slide courtesy of Dr. Bill Bennett from Stanford, California, and looking at meta-analysis of 60 trials in over 5,000 patients. And essentially, there's no difference you can see here other than in a retinopathy of prematurity and maybe IVH grade 2, but there's really no difference in if you looked at all these trials in terms of death and BPD and other very important outcomes that we care about. If we look at the secular trends in PDA treatment and outcomes in the United States, more than 60,000 infants between 23 and 30 weeks of estimated gestational age at birth. There were significant decreases in all trends, and these trends were medical treatment, PDA ligation over time, mortality has come down. The only exception was the increase in BPD amongst the group that were the 23 to 24 week infants. So this is the only increase in trend over time. But these other important outcomes that were looked at, there's been a steady decrease in trends over time. So newer devices have been developed to close the PDA, and this is just a number of devices, show a number of size of devices. The Piccolo device that I'm sure you've heard of at Cleveland Clinic as well, and this is just a series of angiograms showing deployment of that device. I'll let this play again. This is all by a transvenous route, and you can see here the devices can be delivered by a 4 French catheter. This is approved by the US FDA down to a weight of 700 grams. And you can see here, this is a patient. This is a patient that was done by performed this procedure by Dr. Sathanandam, and you can see how the X-ray cleared up within 24 hours in this patient who was 600 grams. So this is the experience from Memphis, and basically you can see here the sub-kilo patients. They've done well over 100 patients less than 1 kilograms at our institution. Also, we've done a number of these patients. And from a technical standpoint, I think it's important for us to relay to neonatologists, and I'm sure the cardiologists there have discussed with you, but it's actually easier for us as interventional cardiologists to close PDAs at a smaller weight, which seems counterintuitive, but often at the smaller weight, these PDAs are long and tubular. Whereas once you get to anywhere between 3 to 6 kilos, although many of those PDAs can be closed, sometimes they become short and fat, and there is really no good device for those PDAs. So it's actually, of course, any procedure is associated with complications, but it's not, for the interventional cardiologist, the smaller is actually better in these cases. So this is just a single center study looking at 100 consecutive transcatheter PDA closures, and you can see here they were less than 1,000 grams. The procedural success rate, these are the highlights from the study, was 100%. So was able to, Dr. Sathanandam's group was able to close all of those PDAs. They had 3% patients who had a major adverse event and 3% with a minor adverse event. I think you're all familiar with the Neonatal Research Network Collaborative, and based on this, you can come up with a scoring system to look at the BPD outcome estimator to see what the likelihood of these patients are to develop BPD. And this is these are some of the algorithms that we and others use in terms of guiding us to see which patients may actually benefit in terms of predicted mortality or BPD risk for us to consider PDA closure if medical therapy is not successful. That slide was at 5 days of age, and this is a similar slide. I'm not going to go over the entire these entire slides for the sake of time, but this looks at the echo at day of life 10 and a similar algorithm supporting the use of transcatheter. TCPC is transcatheter PDA closure when indicated. So what is the role of transcatheter PDA closure in extremely low birth weight infants? So this is just a study comparing transcatheter versus surgical closure. And you can see here that the change in the respiratory RSS score, respiratory score was significantly favorable in the transcatheter group versus the surgical group. Also, the time taken to return to pre-procedure RSS was less, as was the time to extubation. And this is just a slide showing surgical clip with post-ligation syndrome and a PDA device, which we don't really see a lot of that, but it certainly can happen. So I'm just going to go over the hemodynamic and clinical consequence of early versus delayed closure of a PDA. So in this study, they looked at infants born less than 27 weeks gestation, weighing less than 1 kilogram at birth, and they compared, they divided them into 3 groups: those less than equal to 4 weeks of age, those between 4 to 8 weeks of age, and those that were slightly larger at more than 8 weeks of age. And you can see here there were significant differences in the groups in terms of the weight. Looking at the baseline hemodynamics, the PVR was actually higher in those patients who were older, so the pulmonary vascular resistance index. This is really the main slide here, and you can see here that those patients, group 1, that were less than 4 weeks, you can see here that their return to time taken for the RSS to get below a score of 2 was much quicker than those patients who were between 4 to 8 weeks of age and more than 8 weeks of age. So what are the predictors of prolonged more than 30 days elevation of the RSS score? You can see here that procedure age, as we went over, and also procedure weight, which sort of goes along with the age of the patient. I think this is also an interesting finding of the study, and what they found was that specifically between 4 to 8 weeks of age, the weight gain for those patients was much higher, or per day was 25 plus minus 8 days when compared to those patients who were older. So I think that this is also something that that's important to consider, not just the procedure and getting back to respiratory status, baseline respiratory status, but for the overall health and development of these patients. I think that's a very important finding from this study as well. These procedures do not come for free, and you can see here that those patients less than 26 weeks of age were at more risk of developing any major and minor adverse events and other adverse events that were not related to the transcatheter procedure. So complications can happen with any procedure. In general, this procedure has been adopted by many institutions, and the technology is transferable, but complications still can happen. Overall, it seems like the complication rate is certainly comparable to surgical ligation, if not actually better. So what about data versus on BPD? This is unpublished data, but this is also by Dr. Sathanandam's group from Tennessee. And you can see here that they found that the age at transcatheter closure at more than 28 days, and it wasn't the gestation age, but actually the older the patient was, the single predictor for severe BPD in this patient population. So I think you can see the theme here from our perspective is if we can predict which patients may have an adverse event or a bad outcome, it's better for us technically to do them in the cath lab. And more importantly, it seems like the data supports that those patients have a much better outcome in the long term as well than if we get to those patients slightly later in life. And now these procedures can be performed at the bedside. We're still doing them in our cardiac cath lab, but there are some institutions where these procedures can be done have been started to be performed at the bedside, and it's certainly something that is an attractive option for these patients going forward. So finally, I'm going to wrap up because I do want to leave some time for discussion and questions. So I'm going to wrap up with neonatal thromboses. So we know that vascular thromboses are a significant cause of morbidity and mortality in children, neonates with and without congenital heart disease. And it's really one of the most common adverse events after cardiac caths, either in pediatrics and in both pediatric and adult populations. And arterial occlusion has been well documented. Less data on venous occlusions, though, but we are certainly getting there. So in the cath lab, when we do procedures, we always try to avoid entering the femoral artery, and whenever possible, we try to use alternative routes of access, particularly transvenous access, to do these catheterizations, because we're very wary of the fact that arterial trauma can be devastating in some patients. So this is just a patient who was 900 odd grams who had TAPVR, and we ended up stenting the vertical vein. And you can see here we're making use of the umbilical venous line that our neonatology colleagues had placed. And so this procedure was performed in the cath lab, and we were able to put a sheath through the umbilical vein and stent that duct. So whenever possible, I think one of the messages from these slides I want to share is that we always work with our neonatologists, and these small babies will always ask and request that the UAC and UVC be left in place for us to potentially use during the intervention, because it's a free access site that's going to come out at any time, and you don't have to instrument any vessel in the body. When we do perform PDA closure in premature neonates, you can see here we're going transvenous, so there is no arterial puncture to avoid any arterial trauma in these patients. So again, here you can see here that this is just a paper showing that these patients were performed, these procedures were performed by a transvenous route. This is a patient, a 1.5 kilo baby from our NICU who was premature and was born with pulmonary atresia, intact ventricular septum. It was was a very unfortunate case, and we tried to, in these patients, what we're trying to do is we're trying to perforate the pulmonary valve because this is totally blocked. So you can see here I have a stiff wire, and we're trying to puncture through it. We have a snare from the arterial end. We tried to first do it without a snare, just from the transvenous route, but you really do need a target in these patients. So once we put the target, we were able to snare and create a rail, and then we were able to open up this pulmonary valve. Now, we went into the artery. It's important to know, just with a 3.3 French sheath, it was the first stick in the femoral artery, and this patient developed arterial trauma. Never forget this. I never forget this patient. And for those of you who have not seen limb ischemia, this next picture that I'm going to show you is quite telling, and it's certainly something that I continue to use as an example. You can see here that this poor baby's entire right leg above the knee has become gangrenous, and this resulted in above the knee amputation. The patient survived, but of course, unfortunately, has no limb. So we really need to keep this in mind when we're doing these procedures. And it's important for us to use our surveillance algorithms and pathway. So we know that pulse loss is well recognized. This is from one of the interventional cardiac registries. Prevalence rates are varied from 0.6 to 9.6%. In this study, or from this registry, data from 5 centers and more than 3,000 patients showed that the arterial occlusion rate was 1% and venous was slightly less. This is flawed because this really depends on how we are looking for these clots. Risk factors, of course, younger, smaller patients, use of larger sheets, need for repeat cardiac catheterizations. The longer you're in a vessel results in higher chance of that vessel being occluded. And inadequate anticoagulation during the procedure. In these studies, size has been found to be an independent risk factor for vascular complications, with arterial occlusion rates of just over 7% in babies less than 5 kilograms versus 1.4 in those more than 5 kilograms. This is a study that was published from Michigan by Daisuke Kobayashi and Dr. Gowda, one of my excellent colleagues here at Texas Children's Hospital, and they looked at adverse events in patients weighing less than 2.5 versus those weighing between 2.5 and 3.5 kilograms. And there were more than 100 cardiac catheterizations performed, and arterial occlusion was seen in about 3%. And vascular complications, those patients who were less than 2.5 kilograms, vascular complications were seen in 6% versus just less than 1% in patients who weighed more than that. Similarly, from TCH, McMahon looked at those neonates and infants weighing less than 2.5 kilograms and found a 9% vascular complication rate in 34 cardiac catheterizations. What do we know about venous thrombosis post-cardiac catheterization? Early angiographic studies reported rates between 1 to 4%. Predisposing factors, again, the prolonged use of indwelling lines in the ICUs. That's why all of you folks and us are really in a hurry to get these lines out of these neonates whenever possible. Chronic desaturation in the size of the catheter. This is a study by Matthews et al. These are historical studies that showed that this was looking at 22 patients, and they found that all had one cath within 1 day to 11 months of age, and 7 had 2 previous caths in patients diagnosed with IVC femoral vein thrombosis. This was a study by Dr. Barry Keane. They looked at 300 patients who underwent cardiac catheterization, and they found iliac or femoral venous thrombosis diagnosed at later study in 4% of patients. But this has obviously been there has been a trend over time, and I'll get to that in just a little bit. Pulse loss in the cardiac catheterization is reported at rates of 3 to 4%, and iliac vein thrombosis rates at, between 1 to 4%. And of course, changes in our equipment and techniques have greatly decreased this incidence of vascular complications. And you can see here, this is just looking over time. There's been a steady decrease in complications over time. And if you look at this study, this is a more contemporary study of more than 11,000 patients from 1994 to 2006. And there were 161 complications in 1994 versus 41 in 2005. So these are just the guidelines, which I think all of you on the call are aware of. Whenever we have limb-threatening ischemia, we have a low threshold to institute TPA therapy, be it systemic or rarely we will also consider local TPA. It's very important to note, though, that these babies, some of them are actually not able to get TPA due to IVH or other contraindications. And there are some catheters here. These are obviously big catheters, so when used in a neonate, they must be used in the venous system, not in the arterial system. And then for non-limb threatening ischemia, heparin and Lovenox are used from a medical therapy standpoint, and treatment can be given for 6 weeks to 3 months of age, depending on other risk factors that the patient may have. So this is just quality improvement measures. This is a study out of CHOP. This is the study that in the interventional world we quote a lot, and we've been using this algorithm here at our institution also. There was a previous incidence of pulse loss of 4%, and thrombus was seen in 5%. What they found that there was more than 50% treatment success by 2 weeks and 89% treatment success by 12 weeks. So most of the patients had complete resolution, and they were transitioned from heparin to Lovenox. And I'm not going to go over this algorithm in the interest of time, but basically this is their algorithm based on how the limb looks 1 hour post-cath, and whether the pulses are present or absent, and of course, making sure that limb ischemia is ruled out. So first-line anticoagulate is initiated within 4 hours of pulse detection. Confirmatory diagnostic ultrasound performed within 4 hours of pulse loss detection. And heparin versus Lovenox, I think, is a very interesting topic. I'll touch up a little bit upon this in some of the upcoming slides. So what can we do better as interventional cardiologists? I think it's important to to not wait too long for loss of pulse. And this is obviously a very hard thing to predict, because sometimes many patients actually who lose pulses, they're actually able to still maintain perfusion to their limb by virtue of collaterals. But whenever there is an acute thrombosis and there is a white limb, a cold limb, no pulses, we have a very low threshold to institute therapy, and a high index for suspicion to make sure that that therapy is administered and that we consult the relevant services, including plastic surgery and vascular surgery. Heparin versus Lovenox, of course, there are some advantages to Lovenox, of course, less monitoring in the long run, and of course, does not require transition period for outpatient therapy. This is the risk stratification that we use. Also, the high-risk group, those patients are any patient with an arterial thrombus, any thrombus causing limb ischemia or organ injury, such as renal impairment, cardiac failure, occlusive central artery or vein, aorta, SVC, IVC, or symptomatic pulmonary embolism. The key here is symptomatic, because many minor clots in the pulmonary circulation can be treated just with medical therapy and may require a few days to actually weeks to resolve. These are our clinical algorithms here at TCH we use, and basically the patients who, once we identify a thrombus, they're divided into low, moderate, and high-risk groups. And based on that, after cardiac catheterization, we also have a similar guideline where we assess the pulse and we look at signs for thrombosis, order Dopplers, and again, like I said, make sure that the relevant team members are informed ASAP come to the bedside. Actually, we often make sure that multiple services are there at the bedside at the same time to examine the patient. I think the clinical examination is very key in these patients. So I'm going to finish with a couple of case scenarios. This is a 1-month-old, 4-kilogram neonate with had neonatal cardiac surgery with a left arm PICC line in. So I chose this case because PICC lines are not benign, as my colleagues on this Microsoft Teams call all know. These PICC lines can be associated with significant morbidity. This patient developed bilateral chylothoraces that was unresponsive to conventional treatment. He underwent extensive recanalization, thrombectomy with angiojet fetch catheters. These are special tools we use, followed by angioplasty of the subclavian and internal jugular vein. And you can see here, this is what that PICC line resulted in. So where the arrow is complete occlusion of the axillary to subclavian vein. There's extensive collateralization. You can see here that the left innominate vein is then filling here via these collaterals, and then there's a collateralization to the SVC. So if we all recall from our anatomy days, the thoracic duct most of the time inserts into the left innominate vein, right at the left IJ, left subclavian junction. So that would be right here. So given that this left innominate vein is also thrombosed, as is the left subclavian vein, the pressure in the thoracic duct is quite high. There's no outlet for it, and the patient was draining chylothoraces bilaterally. You can see here chest tubes that are in place. Here you can just see us performing angioplasty after we extracted some clot. And you can see here, this is the result. You have a nice patent subclavian vein and left innominate vein now seen. And this is the follow-up 2 days later, and then 9 months later. And you can see here that there's no stent. We try to avoid stents in these patients in the follow-up. So it's really nice flow in this patient, and deliberately we did not stent this patient, and the patient did really well. This is the final case I'm going to show today. This is a 10-day-old neonate with an abnormal aortic arch, dysplastic pulmonary valve, and no stenosis and mild PR, and a PFO on prostaglandin, had a genetic syndrome and a hypoplastic left kidney. Over the course of the day, the baby was noted to have decreased perfusion to his lower extremities and absent pulses in his feet. His lactate rose to 20, and there was evidence of liver injury. He was anuric and started to posture. So I'll never forget this case, because I remember when I was called by the fellow called me and said, Dr. Qureshi, I think this patient has an abdominal coarctation and we need to stent the patient or balloon. My first question to the fellow was, does the patient have a UAC in? And lo and behold, the patient did have a UAC in. And I said, this is not abdominal coarctation. This patient has thrombosis. And so we took this patient urgently to the cath lab, and this is where we're making use of that PDA. So this is a 6 French catheter in this neonate. We've gone through the venous system, down the PDA into the aorta. And you can see here that there's no flow to his lower extremities. You can see here there's hardly any flow getting to his kidneys as well. And this is us using the penumbra system. I don't know if this projects well, but here where my pointer is, you can see here clot is being extracted via this penumbra system. This is what it looks like. It's basically a vacuum extractor. It's connected to this the suction machine, if you will, and you can see here that clots can be extracted while you're pulling them in as well. And this is the angiogram afterwards. There's some improvement, and this is our final angiogram. And you can see here there's good perfusion to the kidney, to both external and common iliac arteries. There are some filling defects. Again, in these patients, we don't want to go for 100% success, just enough that to establish flow, and the rest can be managed via medical treatment. This was quite dramatic because immediately this patient, I remember when we started sucking out clot, one of the nurses in our cath lab, she told me that he immediately started to make urine in the cath lab. It was quite striking, about 85 cc, and then he had excellent pedal pulses. He was on Lovenox that was transitioned off. He's almost 3 years old now, normal toddler and running around. So this is just a picture of those clots that were extracted. So in conclusion, I think that there are a lot of technical advances, as you've seen in this talk, that have allowed for many neonates with complex congenital heart disease to be treated in the cath lab, even at small sizes. I think one has to work within one's own institution to develop protocols that are critical for success. And of course, we must work together as a team with other specialties, such as our neonatal colleagues, to really deliver the best possible care for these fragile patients. So this is just a picture of one of the patients that I showed angiograms in, who had a PDA that was stented. So with that, I'd like to acknowledge the entire TCH Heart Center and our neonatology division here as well. Thank you very much.